Thanks for joining us this morning. We're gonna do a review of our quality improvement program in the department, and then go through some data at the end. And here's a little joke for you to take in here while we're going. So what is quality improvement? So what it is essentially is a process of approaching systematic problems in healthcare. And it's a framework for us to use to be able to do that. It's guided by data, and the activities are designed to bring about essentially immediate improvement in healthcare delivery. So as opposed to when we think about research that takes quite a while to do and to do well, oftentimes years, and then maybe years more to implement that into clinical practice. Quality improvement really gives us a way to do that in a rapid fire kind of fashion. And there are 6 aims that were put forth by the Institute of Medicine, which are safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. And so oftentimes our quality improvement endeavors will focus on one or more of those 6 aims. So we just wanted to review what QI is not. And so to kind of give us a little background on those differences between research and quality improvement. So essentially research is developing new interventions, new data, and new things for the medical world and healthcare. Whereas QI generally is putting that research into practice. So taking what is known and vetted and best practice and implementing that into your clinical practice and the care that you deliver. So research is intended to be generalizable in a great research study to everybody. Obviously, that's not always the case. Sometimes their populations are more limited. But the intent is to generalize data that everyone could then use. QA may apply to smaller areas. It could be a bigger endeavor, but oftentimes QA is happening like in your individual clinic or your institution, rather than your endeavor being meant to help someone in California. And maybe it ends up doing that, but it's typically not the initial intent. For quality improvement, there's no need for controls. So we're so used to research having, you got to have your control group to compare something to, make sure that it's better, or or at least not inferior to. In quality improvement, you don't have to have a control. You can just decide that you want to hit a particular satisfaction rate, and just pick it, and that's acceptable. There's no p-value, and risk is generally minimal in QI. So obviously research, randomized trials, et cetera, there may be some risk that's happening. And of course, in research, they want to minimize that as well. But because QI is generally trying to implement what is already known in best practice, it typically is not incurring a significant risk for your population. And then when we think about QI, we also think about what kind of data sets we may have available to us. And so just because it's data doesn't mean it's QI or research. So sometimes we have data where we're just trying to figure out our finances or our volumes or do our schedules, et cetera. And so not everything is QI. Now, a lot of times you could take a data set and make it research or QI, but a data set inherently is not that. So a common question for folks who are thinking about doing some QI is, do I need an IRB? So that is a great question, and it often is a confusing one because there can be some degrees of overlap where it's not as clear cut. And so this is the website for UW's certification tool, where you can answer a series of questions, and it helps you understand whether you may need an IRB for your particular endeavor or not. It's a great resource. And if we're obviously going to be sharing this slide deck, but if you forget that website, you can literally just Google like University of Wisconsin QI versus research, and this will pop up right at the top of your search. That oval shaped button in the middle there is what you'll click on to go through the tool that we'll show next. but at the top, and then those blue links that that are towards the bottom of the page also will show the decision tree that we're going to show and give you some other pointers on how to differentiate QI to research. So this is the decision tree that they have published in one of those blue links there on the previous page. Um, and what I did here, so try not to get overwhelmed by the mess that you see on the screen, but in the background with the pretty green, yellow, purple, blue colors is what's published. But to simplify it, we overlaid the message, if you will, to share. And so basically, if you go through this algorithm starting in the top left, where it says drug. So if you're testing a drug, you need an IRB. And then, so if you're not testing a drug, you go to next, do you have funding? If you have funding for your thing, then you need an IRB. If not, you can go to the next diamond. And then the question is, you doing it in your own site, or are you doing a multi-site thing, like a multi-institution, endeavor? If you're going with a multi-institution endeavor, you need an IRB. And then if not, you ask the question, are you trying to do an investigation to come up with generalizable knowledge? If you are, you need an IRB. If you're not, the question is, are you going to publish it? And if the answer is no, then it's probably QI and you're good to go. You don't need an IRB. And then if you are going to publish, that doesn't necessarily mean you have to have an IRB. But the question is, would you do it if you weren't going to get professional benefit from it? So from that standpoint, if you would not do that project, if you couldn't publish it and get a professional benefit from it, then you need an IRB. If you're going to do it anyways, you're like, well, I'm doing this project. I hope it works out. This is what I'm doing for my population to try to make their care better. Hey, if it's publishable, that's great. And if not, I'm still doing it. Then you can move on. And if it's in your particular institution or program, then it's QI and you're good to go. And once you go through that questionnaire, that kind of self tool and that oval button that we showed, it'll spit out like a little final decision that you can kind of stick in your file of things in case you get asked about an IRB in the future. Next slide. So just some basics. You want to collect some data to understand your background. So you are going to need, so for example, if I'm going to use just a project that's easy for me to talk about that we worked on, which was a aspirin recommendation project. So if you're going to try to improve your rates of recommending aspirin in accordance with established guidelines, you need to know what your current rate of recommendation is to know what an improvement is. So from that standpoint, you're going to need to collect some background data of some sort to be able to show what an improvement is. Unless perhaps you're instituting something completely new where you know the background rate is 0, then, well, fine. Then maybe you don't. And then you're gonna decide what your initial improvement is, but you also need to show that it's ongoing and continuous. So the hallmark of QI that's different from research is that it's not your classic research study of pre-post. So in your classic research study, you had a pre-population, you did something to them, and then you measured it after your intervention, and there's your study. For quality improvement, the hallmark is that you're going to show something continuous and sustainable. And so you're going to want to be able to show that over time. And that's where we'll get into talking more about cycles and things of that nature. It's also an opportunity to think about culture and improving culture from the standpoint of QI as well. Next slide. So why should I care about QI? There are a lot of different reasons. The number one reason is to make care better. So if you look, anyone who works in healthcare can look around for just a couple of minutes, and there's always going to be something that you can make better, from patient outcomes to patient satisfaction. And so that's typically, the number one thing. Um, Safety, of course. A lot of times people talk about quality and safety together. Even in the titles of things are quality and safety. So those go hand in hand in healthcare. There's also efficiency. So if we can make things more efficient, it's usually better. We'll talk about how we make sure we're not offsetting other things with balancing measures in a future slide. But efficiency is a big one, and then money. There are merit-based incentive payment programs. We may talk a little bit with that with our hysterectomy bundles and things of that nature. Um, as the world churns and thinks more about how to deliver great healthcare, a lot of times the finances are tied to that in certain models. Next slide. So QI, to also help you differentiate QI from research, QI is typically prospective. So if you did something in the past and you are like, huh, I wonder if that worked, then you're typically talking about research. So just keep that in mind. When we think about QI, the whole plan is to be a continuous process of improvement. So just as an example here, going back to aspirin recommendations to reduce the risk of preeclampsia, we think about QI as prospective and oftentimes using a SMART goal framework, which we'll delve into a little bit more in a second. But for example, QI, we might say, we're going to improve the rate of correctly recommending aspirin for preeclampsia to 80% within 6 months. And we're just going to disaggregate that by race. Versus a retrospective research question would be something like, hey, 2 years ago, we changed our aspirin workflow. Did we actually reduce the rate of preeclampsia in our practice? So you can see kind of what some of these differences are between research and QI, hopefully with that example. Next slide. One tool that we will commonly use are things like PDSA cycles, but there are many other tools that could be employed. SBAR, and then from industry, they tend to oftentimes use the Lean, Six Sigma, and the DMAIC model. So in the diagram on the top right, you'll see PDSA. So P stands for plan. So you're going to come up with whatever it is that you want to do to hopefully improve things in your setting. And then you're going to do something. So you're going to carry out that intervention. And then you're going to study. So you're going to look at what happened with that, and this is really important. The study part is really important because there are many times in healthcare where we do something, but we forget to study it. So I'm just going to throw out this example. You recognize that patients keep coming back confused about their post-op recommendations for recovery, their lifting restrictions, let's say. And so you make a handout and you give all your patients a handout that says what their lifting restrictions are. And you're like, cool, I probably fixed that. But then you never studied it. And if you don't study it, then you realize that, oops, 50% of my population doesn't speak English, and I gave them all an English handout. That didn't actually really meet the mark. So we do a lot of things in healthcare, but really important to study that, because then when you study it, then you can realize, oops, I forgot to take that into account. Then you can act again and do your next cycle. So from the standpoint of if you recognize, okay, that first cycle didn't actually go very well because I didn't have other languages involved in my handouts, then next time you do a cycle where you've got all the languages involved. DMAIC is very similar. It define is the D. So you're going to set your objectives, you're going to measure it, and then you're going to analyze it, improve for it, and then control or like make your sustainable plan for the future. So different models kind of getting at the same similar ideas. Next slide. So in research, we think a lot about primary outcomes. We touched on SMART goal very briefly, but I didn't define it in the prior slide. But a SMART goal is oftentimes how you're going to frame your quality improvement endeavor. So specific, measurable, action-oriented, relevant, time-bound, inclusive, and equitable. And I'll just point out, many people might have heard SMART in the past. Please don't forget the IE for inclusive and equitable. It will be better for your patients and it will make your work better as well, because you can move the needle much better if you are not leaving people behind. And so that's where we go from things like you might be thinking, hey, I'm going to make my aspirin recommendation rates better. Well, that's good, but if you frame it in a SMART goal, that's where you get something much more robust. Like, I'm going to improve my aspirin recommendation rates to 80% within 6 months for all patients, inclusive, disaggregated or inclusive by race. Okay, I am going to popcorn this over to Summer, and I'm going to be super hopeful that the people online can hear Summer and not be through the phone. Okay, so measures. This is how we think about what we're going to do in quality improvement. There's process, outcome, and balancing measures. So process measures are measures that look at the process. So for example, again, going back to aspirin, we're going to look at recommendation rates. That would be a process measure. Outcome measure would be the thing that you're actually trying to improve for your population. So outcome measure would be like, did I actually, reduce the rate of preeclampsia? But because of things that have smaller numbers for their outcome or less common or easy to measure, it might be really tricky to use an outcome measure. So like for aspirin to show a reduction in preeclampsia, we're talking about massive numbers. Um, and some of them will be easier. Maybe you're just trying to improve patient satisfaction, and then you could measure that. But thinking about process and outcome gives us different ways to measure things and more granularity for a project. Balancing is essentially trying to make sure you don't create harm. So, for example, maybe you're also going to track how long it takes your nurses to do the aspirin screening intake to make sure that you don't usurp all of their time doing aspirin at the harm of, screening for depression and anxiety in pregnancy, for example. So a balancing measure is a way to assure that you are not causing harm by your intervention. Okay, Summer, next slide.
I'm going to use my phone as the microphone, so hopefully people can hear online a little bit.
I have you up. Okay. I have you up to the computer. If someone can just put in the chat if they can hear Summer.
Yes, we can hear you.
There are many tools that we will use in the quality improvement world to try to visualize the work that we're doing or the problem that we're trying to solve. Here are a few. I think Fishbone is probably the most common that people have heard of, and that's in the middle here, where you make sort of a cause and effect diagram. So you have your problem and you fishbone off of that into what could be potentially causing this problem in different areas, the environment or culture, systems or person. So trying to figure out in a more minute detail where the issue lands. There's the 5 whys, which is somewhat similar in a different visual, kind of trying to get to a root cause from different sub-causes. And then there's process mapping, which will show, and these are examples of many, but process mapping will show, again, in the future, we've done that in our quality committee recently, where you're going through an event maybe that happened and you're trying to retrace the steps and identify where issues may have arisen that you can act on. These other tools or charts are helpful in discerning where you are and where you want to go. So do you need a p-value for QI? No, you don't need controls. You don't need p-values. You don't have arms that you're comparing, but you are looking to see if you have made a difference. And after your major change. So we're not comparing them to publish for research, but we did do something different, right? So we identified a problem in how we, and like our blood transfusion rates. They're too high, they're higher than the national average. And we implemented a protocol to give tranexamic acid to reduce that blood transfusion rate. And we want to know, and we can see that via different charts, if we made a difference or not. As mentioned, some examples of QA work. So this is a process map that I'll get to in a second, but we've got a lot of different initiatives going on, both at the department and the institution level. There's a lot of different ways that you can get involved or make an issue be known. So at the department level, we have the quality committee that Dr. Hartenbach mentioned at the beginning. The quality committee, some notable changes or things that we've done. We've worked with IR. We've heard about IR a lot in our M&Ms, and we've worked with them to help streamline processes. We did a complex case review recently where we did a process map. So anything that is a diamond on a process map is an area that is identified as a potential for action. And so we identified several diamonds. So the two orange ones are the ones that we'll focus on. This is probably hard for everyone to see, but we wanted you to see an example of a case that we went through that was really complex, multidisciplinary, involved many specialties that we walked through from start to finish and found these two actionable items that the quality committee will now work on to improve the systems processes in our department and institution. At the institution level, you've probably all heard of HEROES. They used to be called PSAs, and now they're HEROES, which is an incident report. So anytime something happens that you have concern about or you think could be better, you can file a HERO or an incident report. There's informatics. So informatics at the institution level is often looking at the systems and efficiencies, right? So how can we be more efficient, for example, in the EHR? How can we decrease the burden on the workload or the burden on the physicians and their workload? Not just physicians, residents, APPs, everyone. There's UW Meritor quality teams. So each institution that we work has their own quality teams that kind of mirror what we have in our department. So they do peer review, they do institution systems reviews. We've got some examples of that coming up. One example is an RCA. So at an institution level, when we're looking at systems-based issues and trying to figure out how we can improve, we'll often do an RCA, a root cause analysis. These are long kind of looks into depth into whatever issue might have been identified with a larger group of people trying to find the root cause and make solutions and improve the work. Chart closure is an institution level example that we'll look at. I think we have a slide about. This is an institution-led initiative for us to be closing our charts within 14 days in order to improve many of the things that Katie mentioned earlier. So efficiency, safety, right? It's important for us to all know what was done in a visit if you see a patient next. And money, so if we don't have our charts closed, we're not able to code and bill for that. And SSI bundles. I imagine we've all heard of those. So surgical site infection bundles have been around for a very long time now. They are evolving. We'll talk a little bit more about that in a minute. But they are an example of QI work, identifying an issue, creating a solution and implementing it. And then oftentimes looking back to see if it worked and publishing it. So this is the chart closure initiative that I just mentioned. This is a UW-led initiative. Hopefully most of you haven't heard anything much about it, because that would mean that you're closing your charts in a prompt manner. But what we're trying to do is get charts closed within 14 days. There's a grace period. They give you kind of a range here. So if you're in the acceptable range, if you've got your charts closed within that 14-day expectation. Marginal if it's more than 14 days and greater than 20 charts, but less than 98. So 21 to 98 charts open for greater than 14 days puts you in the marginal category. But if you have 99 or more charts open greater than 14 days, then that would be unacceptable. And there are repercussions. So if you're marginal, usually there's some sort of informal plan for, what's going on, how can we improve this? And then, you improve it and we move on. If you don't, then that can become a more formal, focused professional practice evaluation, or FPPE. And if you're in the unacceptable category, then it just moves to that FPPE. This is over a 3-month period. We're telling you about this in this presentation because it's actually happening right now and it matters. So close your charts. All right. All right, so we're going to talk a little bit about our program. So we have grown pretty substantially in the last 4 years or so, from the Quality Improvement Review Committee to a nice quality program that we are continuing to improve. As Dr. Hartenbach mentioned, we hired Emily as our new program manager. Yay, woo, she's here in person. We have trainees who are involved at all levels of our quality program now, and we'll talk more about that. We have 3 different kind of divisions or levels of the program at this point. So instead of just a Quality Improvement Review Committee, we also have a General Quality Committee, and we have a Quality Education track for our trainees. QIRC, or the Quality Improvement Review Committee, is the OG quality program in our department. It is a peer review committee for our department. So a committee of our peers reviewing the cases in our department, only in our department by our providers. And these cases are submitted via M&M, as you know. They can be metric based, so there's triggers that might send something to the Quality Improvement Review Committee. The quality committee may identify something that needs to be sent, and providers can submit as well. So you can submit on a case that you did or a case that you were involved in, and we can review it. It's comprised of proportionate members from each division. So there is representation from each division and APPs on our CNMs on the committee. And there's trainees as well, as mentioned previously. It's confidential and non-punitive. So the purpose of this is to identify if there are any overlying issues that need to be addressed. It's not to punish anybody. There are, as with the chart closure initiative, there are some formal improvement plans that can be spawned from Quality Improvement Review Committee, only if there is a trend over a longer period of time with a particular provider, and it's never like a punitive process. It's just more of a formal improvement. All right, the Quality Committee. So this is newer in our department over the last 2 or 3 years. It is a committee that reviews systems. So as QIRC reviews it's peer review, the Quality Committee is systems-based review. So it's a process review committee. It focuses on system-based issues. Topics, again, are identified from M&M or providers submitting them, or in your clinic, you might identify something. Or QIRC might say, this is an issue with, how this care was provided. This is a systems problem, and send it over to the Quality Committee. We use various tools for improvements, as you've seen. So there's a champion for a topic most of the time when something is identified in the Quality Committee. And we use process mapping, fish bones, etc., to try to visualize what's going on and come up with suggestions for solutions. We also, in the Quality Committee, review the trainee QI proposals for scholarly projects. So within that education or academic track, if trainees are selecting QI, the Quality Committee is reviewing the proposals and giving feedback, similar to how the RAC does for research. I'm ahead of myself, but so education we are developing. So this is new as we've expanded our education offerings. And so we have the quality track. We give didactics for the trainees, and we're going to do a simulation, an RCA simulation this year with the trainees. And then we're kind of trying to develop a little bit more an education handbook for quality improvement that can lay out some of these things or the items that we discussed here so that you can say, oh, do I need an IRB, or oh, is this research? Just trying to lay things out more easily for people. Our quality chiefs. Last year, we had our first inaugural quality chief, Dr. Barucha, who sat on the quality committee and QIRC. She acted as a liaison to, help between the residents and each of these committees. She helped on many projects. She is integral in helping to develop the beginnings of some of our education. She stayed very busy. And this year it's Dr. Kadispati. So we're excited to continue that chief role, and it's fun. Some examples of what's going on right now. So we have a staple removal project that's happening. One of our CNMs is doing a project that we're working on actively in the quality committee currently. Clinical operations and quality often overlap, right? Like you do a quality improvement project and implement it. And then once it's implemented and found to be safe and sustainable, it becomes operations. So there's many things going on in that realm. There's improving induction. There's improving care and counseling for those with increased BMIs or morbid BMIs. We're doing some contraception counseling optimization. Excuse me. There's a lot happening. And if you're interested in anything or have any projects that you just want to review, you're always welcome to email Katie or I or the quality committee. We're happy to help. Oh, Carol. So Carol emailed, if you were at the faculty meeting, she did give us this presentation talking about a new topic in faculty success where you can input quality improvement projects. So these are non-funded quality projects and research initiatives. It's under QI and continuous improvement or other scholarship research. And when you're in faculty success, this is what it looks like over on the right of the screen here. How will it be used? It gives the QI team some information about what's going on. It provides data for the comp plan. And it gives us information for our annual review, data for the annual review. This is what you would include when you're putting something in so that data will populate into your faculty success CV and be accessible for the reasons just mentioned. All right, we're going to switch gears a little bit from information about quality to data in our department. Katie and I have a couple of things we're going to focus on just to give an idea of some of the data that is collected and reviewed on a regular basis. So for GYN to start, surgical site infection data. So a little bit of background, the standardized infection rate, or SIR, is something that's focused on significantly by almost every institution in the country. It's a risk-adjusted summary measure that compares the observed number of infections to the projected number of infections, and that number is based on National Healthcare Safety Network aggregate data. Okay. It's a comparison tool. It compares how we are doing here in our surgical site infection rate to how others are doing in the nation or regionally in their surgical site infection rate, or SIR. And it is closely tied to CMS reimbursement. The goal is less than 1. Okay. you'll see some data, and just so everyone is on the same page, the SIR that is reported to CMS is for deep and organ space infections only. So if somebody comes in with a port site infection, that doesn't contribute to the SIR. We follow it because it's, we'd like to know that data as well, but it is not reported to CMS for reimbursement. So on this slide, you see our SIR for all SSIs in the first quarter of 2025. These are both inpatient and outpatient, and this is at Meritor. We are, for the most part, above that less than one goal. It's just quarter one. We're not freaking out yet, but we are looking to say what can we do? What is happening that we can improve this, right? Just so you know as well, for Meritor's data, laparoscopic hysterectomies are included and bundled into abdominal hysterectomy. So abdominal hysterectomies are both laparoscopic and open. Excuse me. So this is inpatient abdominal hysterectomy and outpatient abdominal hysterectomy comparison side by side. This is a continuous look at how we're doing. This includes superficial data as well. So it's not just the deep and organ space, it's superficial infections as well. Our trend has been slowly creeping up over the last couple of years into the first quarter of this year. And so we have been looking at this pretty regularly. This is what's sent to CMS. So this is the data with complex and deep and organ space infections for both inpatient abdominal hysterectomy and inpatient vaginal hysterectomy. You'll notice at the bottom that, it looks like, for example, vaginal hysterectomy is, like what's going on, but you'll notice there's only one, right? So there's only one infection, but that's all it takes to kind of make you bump. So it's because of the numbers that they're comparing here. Over on the abdominal hysterectomy side, there's 123, so you can tolerate more infections, if that makes sense. They do control for complexity, patient morbidities, et cetera, for this. But trending up, obviously. I'm gonna go back. I can't go back. Okay.
Can you hit that previous?
Yeah. Sorry, I could just hit the thing. So quickly regarding this, just so you guys kind of get a sense. So this data is discussed on a monthly basis there's a Meritor SSI team and then our quality team in our department. We have, for example, reviewed the SSI bundle. We have really great compliance, like in the 90% compliance with our SSI bundle, both at Meritor and UW. But the quality committee reviewed the SSI bundle to look at the each individual component and assigned it, is it evidence-based? Does it have limited evidence? Is it non-evidence-based? To try to review if there's something within the bundle that we could improve or change that would make a difference here. The committee continues to do work looking at education regarding draping, sterile procedures, et cetera. And so there is active work on this. I welcome any information or suggestions. The quality committee would be happy to work on anything that anyone might have an idea about. But this is something that we are actively, working with Meritor and the data and the quality committee to try to improve. Oh, okay. I'll roll through. UW data is the same, also trending up. NSQIP data is data about, it's UW data only. It's the National Surgical Quality Improvement Program. It's showing complications or issues with our surgical patients, and it's only from UW. So our cardiac, for example, you can have 3 cardiac problems after surgery and that will shoot you up. But for the most part, we're doing good with this. With these patients. I'm going to scoot through this, sorry guys, so that Katie can get to her data as well. Okay, Katie, you should see hopefully your OB data. We have like 10 minutes or less if we want to let people ask questions. Bye.
Perfect. I will be efficient, we hope. This data that you're seeing here comes from our Olivia database. That is a database of obstetric data. If folks have an interest, I'm happy to help you get into that database. You, as a physician, could do so. What you will see on the top graph is all UW C-sections. You'll see over time from 2015 to 2025 that the line maybe sort of creeps up a bit, but you see lots of spikes and troughs along the way. You can see the designated markers 22% in 2015 up to 36% now. But knowing that that is not the median line, that's where literally this line starts and stops. Unplanned C-section, taking out the repeats that are scheduled or the scheduled C-sections somewhere in the 17 to 20% time frame. National rates, NTSV, nulliparous term singleton vertex rates are around 25%, not exactly the same as unplanned C-section rates, but sort of similar-ish. So we are likely in a very good realm from that. From Merida's data that you can pull more specifically, we're doing well. Targets, are in that range as well. Next slide. When we think about our C-section rate, it begs the question, how can we avoid C-sections? One way can be operative vaginal delivery. On the left, kind of an interesting trend over time, you see that our pink line, the forceps rate, has flipped with the gray line, the vacuum rate. My guess, provider hiring preferences most likely is what drives that, but also tells me that we are offering our trainees opportunities that not all institutions are able to offer. 2024 data, forceps around 100, vacuums about half that in 2024. VBAC rates for success, pretty good, 71%. And then on the bottom, maybe an opportunity to think more about it. What we do with our third and fourth degree tears from vacuum and forceps. We've got about a 45% rate of third and fourth degree tears with forceps versus 27% with vacuum. But when we think about how do we avoid a C-section, here's some options. So as a provider, you can kind of, doesn't mean you change your practice, but you know what's happening. Think about ways to avoid that, medial lateral episiotomy, things of that nature. Next slide. Wanting to think about equity whenever we are looking at data, we oftentimes wonder, are all populations the same? The obvious answer is not for everything. Sometimes yes, and sometimes no. So if you have the question, think about disaggregating your data. This is a curiosity of mine, looking at preeclampsia rates over time. All the white, black, and all races sort of follow a similar trend. You see some more deviations from Black race, but that may be explainable by much smaller numbers. But something to look into. Interesting trend and trough around 2021 that unfortunately I cannot attribute to our aspirin QI project that didn't start until 2021. But as we think about our interventions and our QI projects, we can think about how that reflects with our population data. Next slide. This is our obstetrics data that mirrors Summers GYN data. Obstetric data, unlike GYN, is not used for CMS reimbursement purposes. So we are not paid based on our obstetric C-section infection rates in any fashion at this time, but at any point CMS could change that. C-sections are the most common surgery. It would not be a shock if at some point they do change payment from CMS related to that. Numbers wise, similar to what Summer was saying, our infection numbers, actual N's are low, ASOG numbers, complex infections 5, MFMs 0, all infections, the difference is obviously superficial. You can see reflected in those numbers. And we are above the recommended SIR rate reflected in red. There are, next slide, bundles that look at that as well. This is our obstetric SSI bundle on that next slide that you'll see in a second. The red arrows are the arrows where ASOG had a miss, if you will, on a C-section. Not all of these are physician driven. Removing dressings, education about their wound is nursing led. So this is a team effort that requires all parties in the team. Biggest thing for us to think about as physician is our antibiotics dosing. Most of the misses related to like picking cefazolin instead of cefoxitin for unscheduled section, missing the azithromycin, timing not being within 60 minutes. So just being really diligent when you can about double checking, questioning which antibiotics are hung in and which time frame. Ideally, start those an hour before because of the infusion time, so within 60 minutes. But if you start them an hour before, that should be optimized for your patient. Next slide. This is the mirror image of what Summer was showing for GYN. You can see that our SIR rates for all on the left, and then complex, which is deep in organ space on the right, are all above that SIR of 1 that we are hoping to hit, but we are trending down, so looking encouraging. Next slide. This is bundle compliance components. For the sake of time, I will not perseverate on this. Next, what's next? We are thinking about some multidisciplinary conferences, things like ultrasound, radiology, IR, etc. We are excited about developing out our educational offerings and also want to think more about mentorship for QI moving forward. Next slide. And hopefully, I don't know if we have a minute for questions or not.
Yes. We need to do a big round of applause. Questions?
So that I did a lot of SSI work in my department. The infection control committee, the definitions for infections are clear, well defined, but oftentimes the infection control people make decisions based on that particular case. Do you guys get to review each infection case? Because we found a lot of things can change just from how it's fine.
Each case is reviewed. How they're reviewed is different. So at the UW committee, each case is reviewed by every committee member, sent out in advance and discussed at the meeting. At Meritor, it's mainly a couple of people that are reviewing it and then presenting the data. And so there is a difference there, and I agree with you. I wonder if that contributes to the higher levels at Meritor than at UW, but they both are trending up. And interestingly, both places have a trend upward, not just in our rates like hysterectomy, but in colorectal, urology. So all infection rates are trending in that direction.
And one other thing, so that you know about it, we had difficulty getting the data from and part of having a solid part for the department is to try and align with these other systems. But that's something we're going to talk about here and you can help. What's up?
This is for Katie, actually.
Okay, this is you.
I don't know if you can hear me. Katie.
Yep, I can hear.
I'm a big advocate of not using third and fourth degrees as a marker of quality, but I would be very happy to work with the committee on what quality care looks like for people with third and fourths, and how does that look UW versus non-UW, but non-UW providers. Because I think there's a discrepancy, and if that's something ever that the committee wants to work on, I would welcome that opportunity.
Awesome. We'll reach out and see if we can find a mutual date that works for you to attend a committee, because that sounds like an awesome thing for us to consider. Thanks for volunteering.
Trash. She said potential QI project. Why does the tag never work anymore? And RNs for techs have told me that our SSI have gone down since they implemented glove changing. Is that true? Because it doesn't seem like it. And I would say no. It did, like the SSI bundle obviously reduced initially and stayed steady, but glove changing on its own has not changed our SSI rate. And when you have a bundle, you can't take out one thing that made the difference, right?
Yes, that part is very accurate for C-sections as well. Our C-section infection rates are trending down, so we're going in the right direction. We are not able to say that glove change is the intervention that created that.
Yeah. And Irene asked if she can get involved as a not a physician, and I would say yes. I don't know if she's on, but we can reach out to her if she's not on anymore. That'd be amazing.
Yes, we would love to have non-clinicians as well. Brings an awesome perspective. Irene, I'll shoot you an email and see how we can connect.
Great, all right, that is, so you